Hey everyone, this is Jeff Young, kinesiologist, and this is PowerPoint presentation number 1 in a series of about 10 PowerPoint presentations on medical fitness, which I created to kind of set a foundation of what medical fitness is about. It moves in logical progression from general, which is really the purpose of this first one, just to kind of give a general overview of what medical fitness is. And then I start getting more detailed. Just to give a quick example, for instance, the next presentation is on concepts, guidelines, and principles as it relates to the initial consultation and what fitness trainers should know and implement, and also really what medical professionals and lay people should know with all these PowerPoint presentations so they can have an idea of what they should expect from fitness trainers, right versus wrong. But I moved from the consultation to another presentation on the initial assessment, and then the initial program design guidelines for resistance training. The next one after that is safe progression guidelines, especially for people who, well, actually for both chronic disease and orthopedic issues, but with an emphasis on orthopedic issues. And then I also include PowerPoint presentations on aerobic program design, flexibility, and self-myofascial release program design, general principles that everyone should know. And so once again, this one is on just a very general overview. It's only about 8 slides in length. And the truth is, since I set these up to paint an overall picture and to move in logical progression, perfect world situation would be that you would watch all of them so you can get a nice foundation. It'll just really help to understand the rest of the videos that I create, because it'll set a nice foundation for you. But in any case, with all that said, let me go ahead and get into this first PowerPoint. This first slide, I'm actually paraphrasing from a slide in Bob Boone, who is the CEO of the Medical Fitness Association, at a recent Medical Fitness Association conference that I also presented at. This was actually one of his slides, although I'm paraphrasing it, and I'm actually going to bring up the first several bullet points, which you can read as I'm talking. But just to really sum this up, the purpose of this slide is to explain that what differentiates medical fitness and medical fitness trainers from the rest of the fitness world is that we are literally part of the medical fitness team. So we regularly collaborate with patients/clients, healthcare providers, their medical, or in other words, medical professionals, such as their doctors, whether it's family medicine or cardiology, or nutritionists that they might be working with, physical therapists, etc. And so we regularly collaborate back and forth to help design the program, give feedback back and forth. It's really just a situation that should just exist across the board. But this is what differentiates medical fitness from other types of fitness, and that's the purpose of this slide. So this last bullet point, we serve as experts in the prescription of exercise. We merge principles in exercise science and sports medicine with medical guidelines and principles, and we serve as liaisons between the patients and their medical providers across the continuum of care. And then that first bullet point, we also meet the client where they're at, because they're coming with conditions, whether it's chronic disease and or orthopedic issues. And so it's really important to meet them where they're at, as opposed to what you see so much in gyms and health clubs, where the trainer just doesn't really take this stuff into consideration. They don't really know how to design programs for special populations, and they just unfortunately create one size fits all many times. I know I'm painting a broad brush, but one size fits all programs for people, even if they have disease or orthopedic issues. So now we're going to focus on the medical exercise prescription itself, get a little bit more focused. So the prescription itself includes the following components. It needs to have a proper assessment, which once again I'll get a little bit more detailed, especially in future videos. The initial exercise prescription, and then progression, or in some cases regression, for individuals who suffer from disease and or musculoskeletal issues. Part of the point of that is that program design, or exercise prescription, whatever you want to call it, has 2 components: how you're going to start them off, or in other words, the initial exercise prescription, and how you're going to progress them, safe progression. And as mentioned in the previous slide, it also includes the effective communication and collaboration between fitness and medical professionals. This is what differentiates us. The reason why I put this chart up, this continuum, is just to give a little bit more clarity. So on one end of the continuum, we have the clinical stage where, for example, the patient needs, or client, or I should say patient, needs, for example, physical therapy, occupational therapy, or chiropractics if they have some sort of orthopedic issue, or for chronic disease, cardiac, pulmonary, or neurological rehab. And on the other end of the continuum, the person is able-bodied and therefore has no known chronic disease or orthopedic issues. And medical fitness is this transition stage in between, which approximately 70% of people, at least here in the United States, fall into this category. About 70% of people are walking around with disease and or orthopedic issues. So it's unfortunately very prevalent, very needed. From a doctor's standpoint, if they have a patient who needs clinical care, such as one of these that I previously mentioned, they obviously know where to send them. But if they have a patient that doesn't necessarily need clinical care, but can't be trained as though they're able-bodied, that's the problem. That's when, for the most part, doctors don't know where to send them or who to send them to. And that's the purpose of not just this particular presentation, but just all the videos I'm creating, this particular YouTube channel in general. So with all that said, typically, not always, but typically, medical fitness exercise prescriptions, and once again, how they're different from the rest of the fitness world, is they occur in safe clinical settings such as hospitals, physical therapy facilities that, for instance, include a fitness and post-rehabilitation component, chiropractic and wellness centers, etc. They occur under the watchful eye of medical professionals, which means that we coaches need to bring our A game because we're being watched, and that is a huge difference between medical fitness and most gyms and health clubs, where trainers aren't really being held accountable for safe and efficient, effective program design, but rather how much revenue they bring to the gym that they're employed by. So because of these things, the training sessions occur at a much higher standard, usually in most cases by degreed fitness professionals. So in other words, kinesiologists and exercise physiologists, where we adhere to the governing body principles and guidelines, or in other words, the American College of Sports Medicine, the National Strength and Conditioning Association, which are the two governing bodies in exercise science, but also governing bodies guidelines such as the American Medical Association, Heart Association, Diabetes Association. Moving on. So medical exercise prescription includes two categories: chronic disease and musculoskeletal issues. Examples of chronic disease issues where the person either doesn't need clinical care or they were discharged, such as from cardiac rehab, but you can't train them as though they are able-bodied. So these are just examples which I'm sure everyone is familiar with because unfortunately they are so prevalent. So I'm just using this slide to give more clarity to the previous slides. And then examples of musculoskeletal issues where you don't necessarily need clinical care, or maybe you had it, such as physical therapy, but you were discharged, but you can't be trained as though you're able-bodied. From a knee standpoint, I'll just let you read the bullet points. Spine, common issues, including some of the ones you may not have heard of, such as the spondies, and shoulder issues. So these are all just examples of situations where you don't necessarily need clinical care, but you sure can't be trained as though you're able-bodied. This gives more clarity as to what medical fitness means, what it's about. So the hardest part of medical fitness, at least from a coaches or trainers standpoint, and at least initially, is learning what I call your red flags and golden rules for each condition. It's hard for two reasons. Number one, because there are so many conditions, and number two, because we have to learn medical jargon or terminology that we didn't learn in school or as part of our certifications. So that's what makes it hard, at least initially, what makes medical fitness hard, at least initially. So more specifically, what I mean by red flags is where we may need to terminate or adjust the session because the person is feeling dizzy, lightheaded, nausea, the other adjectives that you see there, which you can sum up as feeling other than the norm. And from a program design golden rule standpoint, what I mean is that we, the coach, need to understand for various conditions how we need to adjust our program design based on the condition. So there's way too many to list, but just for example, if the person has diabetes, we, the trainer, need to understand what the safe blood sugar ranges are and to make sure that the client is in safe blood sugar range prior to every single session. From a hypertension or high blood pressure standpoint, we need to be cognizant or sensitive about Valsalva maneuver, which means holding your breath for too long, especially with a closed flap, a closed glottis, extended isometric contractions, heavy overhead presses, things like that. And from a lung disease standpoint, such as COPD or pulmonary hypertension, we need to understand that as we're designing programs, at least initially, we may most likely need to lower the overall intensity, longer rest periods between sets, maybe single joint exercises to begin with rather than things like squats or deadlifts. So that's what I mean by program design golden rules. And then another really important point for everyone to understand. Trainers need to really understand this, but medical professionals too, so that they can understand what to expect from their trainers when they refer patients. And then the client themselves need to understand this, because if a trainer is not doing what I list in this particular slide, then it should be a red flag to the client that maybe this trainer shouldn't be my trainer. And so what I mean by that is that if the individual has eaten, if they are hydrated, if they've taken their medications, if it's applicable, if they're diabetic and they've taken their checked their blood sugar, if they perform a proper graded warm-up, and what I mean by that is that the warm-up starts off light and progresses a little bit in intensity during the course of a warm-up, and if the session, if needed, if the session volume is adjusted, such as lowering volume or intensity, then it's really rare that a negative event, such as feeling dizzy, lightheaded, like you're going to pass out or something like that, or nauseous, it's really rare that it's going to occur if the coach has made sure that those things occur and if the client has made sure that they've eaten, they're hydrated. So it's really important for the coach to check prior to every single session to make sure that the client has eaten and they're hydrated and if they've taken their medications, and to perform proper warm up and adjust the session intensity and volume as needed. Really important to understand this. And then from an orthopedic standpoint, what I mean by red flags and golden rules, we'll start with red flags, is where once again you may need to terminate or adjust the session. And since it's an orthopedic issue, it is always going to manifest itself in the form of pain or discomfort, especially sharp stabbing or burning pain, any pain that's above a 3 on a 1 to 10 discomfort or pain scale, if it's early on in the joint range of motion, numbness or tingling, swelling or inflammation, especially when it affects joint range of motion. So these, once again, are red flags that the trainer or coach needs to be aware of, where it's either out of our league, maybe we need to refer off to a physical therapist, terminate the session, or adjust the session somehow, such as lightening the load, changing the angle of exercise, changing the exercise selection. And from a program design golden rule standpoint, I'm actually just talking here about things that we need to know that may exacerbate pain if we aren't aware of them. So for examples would be for a herniated disc, we need to be wary of too much flexion, rotation, or I also should include a compression there. From a stenosis or one of the spondies, such as spondylolysis, spondylosis thesis, spondylitis, those are conditions where too much extension will exacerbate pain. And then arthritis is an example of something where we need to be aware of too much compression or torque in the exercises or movements. So this really sums up this PowerPoint presentation on medical fitness to give you a general overview of what it's about. The next one is going to be concepts, guidelines, and principles as they relate to the initial consultation. And I just really hope that you will watch the series of PowerPoint presentations so you can really get a good idea of the theory behind medical fitness, which will help you understand the rest of the videos that I create as I get into more detail. So if you're watching this on YouTube, I hope that you will comment below if you have any questions. And thanks again for watching, and I'll see you in the next video.